A very good morning. Apologies for the delay. My paper that has been given to me is the PRO-based trial based out of the Germany. This thing, as we all know, the European countries have a public screening program, which is not yet there in India. And this is related to it. This paper was published in the EAU September 28, 2023. What is the background behind it? So they already had a PRO-based trial prior to this, which is probably called as the PRO-based 1, which basically relied on the PSA to understand the screening program that they run. Anything over they screen all people, public at the age of 50 with a PSA, and anything more than 3, they take into consideration whether to evaluate further or not. Now, standardized MP-MRI combining T2 weighted as well as diffusion weighted and DCE provides very high accuracy for clinically significant prostate cancer, and it facilitates target biopsy. It has the potential to exclude non-clinically significant prostate cancer and possibly reduce the unnecessary biopsy rate. However, it is still very unclear what is the performance of the MRI and what is the outcome of the MRI screening in patients at the age of 45 years. So the new rule that they have put forth is that we should start screening at the age of 45 years, and that is where this confusion comes into play. So the aim of this study, PRO-based 2, for all practical purposes, is the analysis of the ability of the MRI to detect clinically significant prostate cancer of at least Gleason group grade more than 2 in men aged 45 with a confirmed PSA of 3 or more in the PRO-based trial. So the first one that was done was only a PSA screening test, whereas here it's going to be done along with the initial PSA screening followed by an MRI. So it was performed at 4 sites in Germany, in and around cities of Düsseldorf, Hanover, Heidelberg, and Munich from 2014 to 2019. So the entire total number of enrollments was about 46,642. Now they were randomized into 2 groups, whether you're going to do the PSA right away at 45 or you're going to delay the start of the PSA screening at 50 years to determine whether it is going to change your protocols. So the participants in the immediate screening group, that is at the 45 years of age itself, will undergo test of PSA, which will then be divided into 3 subgroups. One was a high risk group where the PSA is already 3. Then the intermediate risk group where the PSA is between 1.5 to 3, and the low risk where the PSA is less than 1.5. MP-MRI was offered to all participants in the high risk group, and all participants with a confirmed PSA 3 were referred for biopsy irrespective of the findings. So the MP-MRI were basically analyzed by the local radiologists in that center. However, they submitted all the MRIs to a senior radiologist with more than experience of 10,000 MRI readings, and they were cross-referenced with them as well in order to find out whether there is a correlation between the experience of the MRI reader between the prediction of PIRAT's scoring. Now, the prostate biopsy were conducted as MRI plus or minus transrectal fusion that they did. They also subdivided it as a standard template biopsy versus the standard plus targeted template biopsy. Now, the local reference readings were compared. They evaluated PSA level, ISUP grade grouping, MRI data, and different prostate imaging data. And they also qualified the MRI. What was the degree of the quality of the MRI by the PQL system, which is the prostate imaging quality scheme. Now, this is the entire flowchart of the trial. So 46,642 were enrolled. Arm A was the immediate PSA which was done, and Arm B was the deferred PSA done at 50 years of age. Now, in those people, they were divided into 3 subclasses, which is the low risk. I'm not sure where to show. Okay. Low risk is the one with less than 1.5, and they were not done anything. Intermediate risk was about 1.5 to 2.9, which was followed up. And high risk is the group that we are targeting, 45 years of age. More than 3 undergo MRI. So out of the 149 patients, depending on the MRI report, they were referred either for a biopsy or for the biopsy depending on the PIRAT scoring. Now, of which, in the 114 cases which underwent biopsy, 47 had not to have cancer. So this was the final flow chart of the entire 46,000 people who underwent the screening. If you look at the Arm B, there was a 107 withdrawal out of the offer of DRE alone. Now, underwent DRE and they found significant DRE changes in the prostate. Then they were results of it. I won't delay it too much. So basically, this was the 114 patients who underwent the biopsy. The median PSA was about 4, not 3. It was more than 3 what we have found. And the median prostate volume was around 32. And coming to the Gleason grade group, about 14% of them had grade group 1, 29 had grade group 2, and 2, 1, 1 are the 3 and 4 and 2. So basically, clinically significant grade groups were actually less in this screening program. Now, coming to the PIRAT score, they found that 50% had PIRAT score of less than or equal to 2, 34% and 14% of 3 and more than 4 respectively. So these were the clinically significant appropriate for a biopsy as well. Now, coming to the comparison of detection by PIRAT score on local and reference reading. Now, this is where they have very much characterized that there is a definite role of the expert MRI reading, and it made a lot of difference in changing the protocol in classifying the PIRAT scoring as well. So this is very important. And the AUC was 0.63 for local reading, whereas 0.84 for the reference reading with experienced MRI readers. Prostate cases, 57% were detected by both biopsies approaches, whereas 30% were detected by systematic approach alone and 13% were detected by targeted biopsy alone. So that was also classified into the this thing. Now, coming to the accuracy of the MRI on detection of clinically significant prostate cancer, you can see when compared to the local reading as well as the reference reading, there was a definite increase in the detection of clinically significant and upgrading of the PIRAT scoring depending on the experience of the MRI reader. So it makes a lot of sense that a person who's reading and qualifying the lesion or the prostate as a PIRAT score should be at least have read more than 10,000 MRIs. That's the criteria they have given. Now, coming to the discussion. Now, this cohort of exclusively young people, which I don't think we even do the testing at a certain point of time, differs considerably from the population of older men, which are usually referred for the screening or MRI for detection. A higher proportion of their cohort was scored as PIRATs 3 by both the less experienced local radiologists and reference PIRAT experts, predominantly showed only diffuse or non-focal changes on the T2 weighted as well as the DWI, which can be classified as PIRATs 3 according to the version 2.1. It's very age specific. Is it anything different from the older people? Something, or it may change into malignancy later, is something we need to understand. What makes reading even more challenging, the prevalence of smaller and lesser aggressive tumors, is that as 90% were only GG1 and GG2 and not the more than GG grade group 3. Now, importance of the expert reading, it led to the detection of 24% of additional clinically significant prostate cancer, and it avoided biopsy for PIRATs 2 on the reference reading, thereby reducing the number of biopsy by 20%, at the same time not missing out of any clinically significant prostate cancer. If only men with PIRATs 4 on reference reading had been biopsied, 21% of clinically significant cancer would have been missed, whereas 68% of total biopsy would have been avoided. So this makes a lot of difference. Now, limitations, it is basically triggered again by PSA. So we are reliant on the PSA basis alone. So low PSA, clinically significant cancers are missed out. The MRI value of the prediction of the PIRAT scoring has become very relevant with the expert reading. So it makes a lot of sense that our radiologists have to upgrade. And the exact correlation of MRI with the results of systematic and targeted core biopsy, they were not a part of this analysis. Though they have recorded it, they have not analyzed it. So we do not know whether what is still the standard of biopsy care. And from the initial group of 186 men, full MRI and biopsy data were available only for 114 participants, as the MRI results had influenced decision against the biopsy and they have to be taken out of the cohort. Prequel data were analyzed retrospectively, and this study does not allow any conclusions regarding the impact of this metric on the cancer prostate detection. So to conclude, my view on this study is that this is the first study for people around 45 years of age. I don't think in India we do any screening at this age point. So this is something which is quite novel, as well as not possibly imploring us to do this at this point of time. However, as compared to PSA and MRI-based screening in the elderly, reading in a younger patient, especially with a higher PSA, is fraught with much difficulty that experienced radiologists and probably a second opinion on the radiologist is very, very important before we offer biopsy. These results suggest that quality control measures and double reading in expert centers are needed if it is to be introduced as a screening tool. Thank you.